Good morning, everybody. I would not say that talking about preventable Nebraskan death is my favorite subject, but it does seem to be a recurring theme. And we're going to start that way, talking about COVID-19 a bit, and then move on to a little bit of an update regarding what is happening in Uganda. I am a bald, middle-aged white man, but I am not James Lawler, so don't blame him for anything that I say, unless you want to. So views are my own and not necessarily any agency. And if you are not already vaccinated against COVID-19 and pursuing both influenza and bivalent COVID-19 vaccine doses this fall, then sadly somebody has lied to you. And so I showed this table back in May, death from COVID-19 in the numbers. And unfortunately, one will immediately see that even though we have adopted some complacency and apathy regarding the burden of disease with COVID-19. If you look at the rightward two columns, the 7-day rolling averages, you have May of 2020, right at the moment where we really started to understand the realized magnitude of the pandemic. We're almost twice the rolling 7-day death count in the United States right now. And our cumulative total of Nebraskan deaths from this pandemic continues to climb. It's about 8% higher than when I showed you in May. So we're marching along steadily in the accumulation of that burden, and a reminder that burden is substantially higher than the combined Nebraska deaths in World War II, Korea, and Vietnam. And unfortunately, other countries in the world that have been a little bit more effective, even though closer to some of the swirls of variant emergence, have frankly done a lot better. So something to think about. Now, if you are planning on going to Thanksgiving this year, and you would like to protect grandma, grandpa, and the cousin you mildly like, who's about 40 years old, undiagnosed, pre-diabetic, glucose intolerance, and smokes, I strongly suggest that now is the time to get your bivalent booster and also to be vaccinated for influenza. If, however, you are skewing Thanksgiving this year and you are looking for another reason to engage and promote in the areas where you work and play the value of vaccination, then I suggest that following the money is a fine thing to do. So this is a very good medical economic report from the Commonwealth Fund. And what one sees is that vaccine uptake against COVID saves money. There's really no other way to put it. And it saves money on the scale of billions to tens of billions of dollars over the course of just one season. And so I think this is a town that ought to understand the value of smart investment, and promotion of vaccine uptake above where we are and towards optimal levels will save a lot of money. And that's money that can be used for growth, innovation, education, other things. So save money, get vaccinated. Now, COVID-19 is not the only respiratory disease with increasing numbers this season. This is a graphic from the Centers for Disease Control, and it's from their weekly uptake. If you're not used to looking at these, then if you look down on the bottom, the MMWR week is the week in the year. So we are at about week 40 there on the right. And you can see that it's divided by years. And what one sees is if you look at influenza cases, we're on the rise, and we are climbing in influenza burden. The numbers are still low, but for beginning of season, they're actually high. And so we are experiencing a climb in influenza. So why do I harp on this? One is that seasonal influenza is bad enough to be getting on with in any year. But last year, we talked about the value of looking at influenza in concert with COVID-19. And Dr. Matt Donahue and others at Nebraska at the state level did a fine job of integrating a respiratory illness dashboard. And we see on their website, COVID-19, influenza, RSV, and one sees immediately that follow the red curve, that the red curve is already, even in Nebraska, with positive tests, emergency department visits, climbing above where we were in 2021. And you can see that there was a stark climb just before Omicron with influenza that then probably got replaced with the Omicron wave. But this matters. So why talk about this? Why talk about this climbing rate of influenza? Well, one is, again, influenza is starkly impactful for the same individuals who are likely to have poor outcomes from COVID-19. The other reason is, and what we were discussing predominantly in that piece whose headline I just showed, is it is a good indication that we are not doing what we ought generally for respiratory illness, hygiene, and protection in the community and in the workplace and in schools. And we know this from the news, talking about hospitalizations among children with RSV, adenovirus, influenza, in a run into a period where we also are likely, as the news is also discussing, to see the next wave of variants from COVID-19. So it's a good bellwether that we need to be more vigilant. Get vaccinated now. Now, I know there's some curiosity about what is happening in Uganda. And, one more slide actually about SARS-CoV-2. Now, early in the pandemic, we were experiencing a lot of replacement. So influenza was high in 2019, so high that the National Institutes for Health in the fall of 2019 actually had identified seasonal influenza as its number one priority for novel vaccine development and research to interrupt the threat nationally and globally of seasonal influenza. Seasonal influenza is bad. And then in 2020 and also 2021, we largely saw replacement with SARS-CoV-2. And that replacement with SARS-CoV-2 in terms of what we observed in influenza-like illness and severe acute respiratory illness in the United States largely was one variant, maybe two variants at a time. So what I'm showing you here is Dr. Joseph Fowler's favorite website. So this is next strain. And what you see is the time course phylogeny time on the x-axis, if you look in the left upper quarter, and the different colors represent different variants. And what you see in late 2020 and in 2021 is that, for the most part, when there were lots of specimens available to sequence, they tended to be one color, they tended to be one variant. What we've started to see here in mid-2022 is that we see multiple circulating variants at a time, and we see them in a way where they persist over time. So this whole phenomenon of replacement, where you see one single SARS-CoV-2 virus flying around, it has passed. And it may happen again, but what we now see are lots of SARS-CoV-2 variants persisting and causing problems. What that means is replacement is less of a phenomenon, and we're going to see more and more co-circulation with all the things that had been replaced by SARS-CoV-2, just like we're seeing in pediatric emergency rooms and ICUs around the country with RSV, adenovirus, and influenza, and we'll soon see that more largely in the adult population as well. Consequently, thinking about respiratory illness holistically, thinking about it in terms of safety, where workplaces are monitoring their absenteeism, being proactive and facilitating the self-reporting of illness, being mindful that if you're sick, you're probably right that you're sick and probably don't want to be in aggregated settings with others, and being proactive with vaccination and respiratory and hand hygiene. All of these things matter, and they matter for Thanksgiving, and they matter for the economy. Well, what is happening in Uganda? The Ministry of Health of Uganda has a very good website, actually, and I provide for you the link in the bottom right corner. the outbreak that is happening right now in Uganda, mostly in central Uganda, although where you see the colored districts of the country, but there are also now cases in Kampala, predominantly referral cases in structured care settings, although I heard an indication that there might be local acquisition as well, but we're waiting for more information on all of that. In the bottom left is a graphic that was provided by the European Centers for Disease Control using data from WHO and the Ministry of Health of Uganda and the government of Uganda. And what one sees is that Uganda has been pretty aggressive at interrupting escalating scale of the emergency. So when I've seen these outbreaks in the past, I haven't seen a lot of them, but I've seen some. What tends to happen is every 1 to 2 weeks, you see an increase in scale of about 2 to 3-fold. And so it could be that this emergency in Uganda is past peak. But as you see in the numbers to the right that have been reported by the Ministry of Health of Uganda, there's still nearly 100 confirmed cases, about a 1 in 3 mortality rate. And so it requires a lot of energy by Uganda to intervene. So what is this about Sudan, and why might it be different in terms of how we manage it from what we know about Zaire? So there's a nice website called virological.org where virologists geek out with each other online. And Dr. Shannon Whitmer posted this nice phylogenetic tree using the sequence that's highlighted there in the bottom left from the current outbreak. And the reason I show this to you is not so much to make you an expert in molecular epidemiology, but what matters in these trees is the distance from the left. So forget a little bit about the stacking and grouping that's happening vertically. Look at the distance from the left side of the page to the right side of the page. Now, I have my cursor up here on the top, and I have if you can you see my arrow? Can anyone see my arrow?
Not really. I don't see it, David.
Okay, I don't know if it's going to let me.
There it is. Oh, there it is. I see it. Yeah.
So I'm pointing. Thank you, Shelley. So I'm pointing right now at Zaire, and this is Ebola. This Ebola virus, Zaire. It's what caused this particular one, identified in Guinea, was identified during the 2014 to 16 epidemic in West Africa, and one can see that the left to right distance among the Zaires is really small compared to the left to right distance that would be required to get from the Zaire down here to the Sudans. And so that distance matters, and it matters principally if you look on the right side with the glycoprotein. So a lot of the medical countermeasures that we've developed, the monoclonal antibodies in particular, and the vaccine, have taken advantage of the sticky knob on Ebola virus. Now, this is not unusual. It is the sticky knobs on influenza and the sticky knob on SARS-CoV-2 that were the readily accessible targets exploited in the vaccines with which we are familiar for both of those conditions. So that part's not all that unusual. But what I show you on the right is just how different that immune response is. So remember, there is a Merck product, the RVSV ZEBOV, as it's called, vaccine that is used for healthcare worker protection at referral centers like ours in the United States, as well as broadly in communities that experience Ebola virus Zaire, Ebola disease Zaire right now. And what one sees in this nice paper in Cell using pseudoviruses, it's actually a nice product from Dan Chertow's group out of NIH, where they took survivor antibodies, so that target the glycoproteins, so a really diverse array of antibodies, and that would encompass some of the general domains that are targeted with the vaccine and the monoclonal antibodies. And what you see is that when it's blue, the bars are pretty high. This is immunoresponse in rabbits when challenged with pseudoviruses. So in the blue with Zaire strains, it's really high, and in the red with Sudan strains, it's really low. So it seems like one might have guessed that, looking at the phylogenetic tree on the left. But the point being that monoclonals and current vaccines that are available for wide distribution are less effective against Sudan. And so one might expect to see case fatality rates, disease in patients, and community burdens that are much more like the early and mid part of the 2014 to 2016 emergency. And so how are they doing against that emergency? Well, case fatality rates, figuring that out in West Africa was really problematic. I have friends at the London School who did a fine job of trying to assess that. And it's really a mess because it was so heterogeneous. This is a smaller emergency in Uganda. They're being pretty aggressive. They probably have about a 20% better case fatality rate on relative terms than what was seen in West Africa initially. There may be some activity from the drug remdesivir. Remdesivir is broadly used globally now for SARS-CoV-2. And so there's some thinking about that. There also are monoclonals and vaccines in the research development pipeline. And so fielding those is being discussed as well. So we covered a lot of ground. Get vaccinated. Be nice to the cousin that you only mildly like by getting vaccinated. And if you're not doing Thanksgiving, remember vaccination equals community wealth and wellness. And so do it. And keep an eye on Uganda. We should all be have them in our thoughts and prayers. We should all be respecting how aggressive and professional they are being. And we should all be thinking about what that means in terms of what additional support they may need, and also what that might mean for us as a referral center. Thank you so much.